So again, thanks everyone for joining. I'm going to be talking about normal variants and don't touch lesions in neuroradiology, which is very important because when you're reading cases, it's important for you to be aware of these variations and make sure that you make the appropriate diagnosis and potentially don't recommend any procedure for something that's just a normal variation. Or vice versa, mistake real pathology for a variation. So I don't have any relevant disclosures. And I'm going to start with brain parenchyma. And one of the most common variations that we see in the brain are perivascular spaces. That they can be in any part of the brain. Here you can see a patient that is in prominent perivascular spaces in right frontal subcortical white matter. They're bright on T2, they're dark on FLAIR, and also they don't enhance. So this is typical perivascular space. They're common around anterior commissure and brainstem, but basically you can see them in any part of the brain, and they can have atypical imaging appearance. It's a review that we actually published a few years ago. If you're interested, that you can go and look at the images and read in more detail. But basically, as you can see here, can have them more commonly in areas like this, adjacent anterior commissure, subcortical white matter, in the brainstem. But you can also see them in posterior fossa, atypical appearance. We don't see that every day, but again, this is a prominent perivascular space. And this is a patient with a giant perivascular spaces in the brainstem that actually was so large and caused mass effect to the point that the patient required shunting of CSF. So even though they're normal variation, and for the most part, they are don't touch lesions, but rarely they could cause problems for the patient. They can also be seen in the context of some systemic diseases. For example, in patients with mucopolysaccharidosis, you can have prominent perivascular spaces, as you can see here, also associated with some FLAIR signal abnormality. And another variation of perivascular space, which has atypical imaging appearance and was kind of recognized by the neuroradiology community a few years ago, are these prominent perivascular spaces in the temporal lobe that they are associated with also T2 signal abnormality, as you can see here. But again, typical location and typical imaging appearance in terms of a cyst, some FLAIR signal abnormality, really not a lot of mass effect and no enhancement. So that should basically direct you that this is a prominent atypical perivascular space in the temporal lobe, and this is not, for example, a cystic tumor or a neuroglial tumor. If it was, we would expect some different imaging appearance. For example, we would expect it to see some solid component, some enhancement. We don't see any of that here. So again, this arrow shows the abnormal FLAIR signal intensity. This is a relatively new entity that it has been recognized in the past 10 years or so. And again, this can be similar to perivascular space in some aspects, because on T2, it's in the subcortical location. It has this multiple T2 hypertensive like grape-like appearance, but the difference is that it doesn't suppress on FLAIR. And so that's why this is not a prominent perivascular space. This is a tumoral entity called multinodular and vacuolating neural tumor of the cerebrum. This is a patient at Penn that came to us with vertigo and nystagmus. And this was just an incidental finding, and the patient was followed, but no change. This is an excellent paper published in 2017 in AJNR, talking about this entity, that typical imaging appearance that T2 hyperintense, it's also hyperintense on flare and almost never show restricted diffusion or contrast enhancement. So this entity kind of shifted a little bit. So first it was called a tumor, then it was called the hamartoma. But again, in the new version of the WHO classification, again, it is classified as a tumor. But again, the one thing that everyone agrees on, that this is kind of indolent benign lesion and frequently found as an incidental finding.
Sorry for interrupting. Could you please accept some of the participants? They are in the waiting room.
Yeah, sure.
Thank you.
See participants. Okay. Thank you so much. I think there was only one, but please let me know if
Thank you.
there are more. All right. So moving on, this was a patient that had atypical kind of MVNT. Unlike the previous case that I showed was in posterior fossa, a multivascular nodular tumor that can be also found in posterior fossa. But again, when we talk about perivascular spaces, it's important to be aware of the anatomy of the perivascular spaces, and that different diseases can spread in the brain using the perivascular spaces as the conduit. This is a patient with neurosarcoidosis that involves the perivascular space. This is a patient with intravascular CNS lymphoma, again, involving the perivascular space. And finally, you can see this patient at the very bottom, a case of Klippers, which is a chronic lymphocytic inflammatory disease of the brain. That again, this is the typical imaging appearance that you can see enhancement along the perivascular spaces in the pons and posterior fossa, and to a lesser extent in other parts of the brain. It's called Klippers, abbreviation for this disease. So moving on to choroid plexus. Choroid plexus xanthogranuloma can be seen frequently in neuroimaging. You can see calcified choroid plexus xanthogranuloma, and on CT, on MR, again, it can be bright on T2 and flare, and also it can show restricted diffusion. Can I ask the audience to mute yourself? There is some background noise. See if I can do that myself. All right, should be good. This is actually a patient that a neurologist once came to me, and with these images, and the neurologist was concerned about patient potentially having a mass. And I can understand the concern because there are these two intraventricular structures that show restricted diffusion, but this is just prominent choroid plexus xanthogranuloma. Restricted diffusion is just because the cyst content is just proteinaceous or like thick and show restricted diffusion. It doesn't mean that there is any cellular tumor or anything like that. Again, being aware of this entity is very important, not to misdiagnose for serious pathologies. Moving on to hypothalamic adhesions. As you know, hypothalamus has various nuclei, and there could be some adhesions between these nuclei at the midline, various nuclei. You can see arrows, various patients with hypothalamic adhesion. And when you look at hypothalamic adhesion in the sagittal plane, it can look like a hamartoma in sagittal plane. But when you go back and look at other planes, especially coronal and also axial, you can see that you're just dealing with an adhesion band between the nuclei of hypothalamus. And so this was a controversial entity at some point in the literature, and some researchers believe that there could be some midline anomalies coexistent with hypothalamic adhesions, but later papers showed that when they looked at a larger number of patients, that they found that most of the time there are no structural abnormalities, and hypothalamic adhesions maybe just incidental findings with no clinical significance. And also this has been our experience at the Children's Hospital of Philadelphia, that we had about 36 subjects, and none of them had any clinical symptoms referable to hypothalamic pituitary axis or are there any anatomical abnormalities. And so we also concluded that these are most likely incidental lesions. So I'll show you a few more examples. This is again a hypothalamic adhesion here. When you look at the axial, it is clear that we're not dealing with a mass. This is just an adhesion. This is a hamartoma, which looks like a hamartoma on sagittal. And when you look at other planes, again, you can see that this is a true mass and very different from adhesion, which is just a band that connecting the hypothalamic nuclei in the midline. Caudate tail is an interesting structure in the brain. When everyone talks about caudate tail, everyone usually refers to caudate head and body. And sometimes, especially trainees, forget that caudate is a very long structure, and it has a tail that travels all the way and to the temporal lobe, and finally will connect to amygdaloid body. And so the caudate tail, when it is adjacent to the basically temporal horn, can have variable imaging appearance. And this is a study that we did many years ago. We looked at high resolution MR imaging in the temporal part of caudate tail in children. And we saw that there is significant variation in the caudate nucleus tail part. In some patients, it is very nodular and kind of protrudes into the ventricular system. In some patients, it is visualized, but it's kind of more linear. And in some patients, we can't even see it. It's so small that it's not seen on even on high resolution 3 Tesla imaging. And again, in some patients, it's nodular, but kind of protrudes into the brain parenchyma, and in some, it's kind of in between. So the long story short, there is significant variation in caudate tail imaging appearance when it comes to the temporal part, and when where it is adjacent to the temporal horn. And so it is important to be aware of this and know that when we see something like this, is it caudate tail or is it a nodular heterotopia? And the key is that the anatomical location, if you see a gray matter structure in the kind of superior aspect of temporal horn, that's caudate tail, that just could be prominent. And the best thing is just to follow the slices, the coronal slices, to see if it is continuous with caudate tail, compared to something like this, which is nodular heterotopia. And location-wise, it is located lateral to the temporal horn compared to the superior. And this is a nodular heterotopia, which could be the cause of epilepsy for in this patient. So again, very important point that attention to the anatomical location would be able to help us to make the appropriate diagnosis. Hippocampal digitation when you're reading patients with epilepsy. The kind of the contour of the hippocampus could be kind of variable between patients. In some patients, it's kind of smooth. In some patients, you see some undulations, and in some patients, you see a lot more undulations. This is part of the kind of normal spectrum of variations. And again, this is a high resolution imaging of hippocampus on 7 Tesla, and you can see that. Can see the undulations very well. And the more kind of high resolution magnet you have, the better you will see these kind of interdigitations and lobulations of the hippocampi. And so again, it's important to know that there could be significant variations in this regard between patients. Moving on to Wallerian degeneration in the brain and cord. Again, this is a review that published quite a few years ago. And the reason that we did that was that when we talk about Wallerian degeneration, especially for trainees, everyone thinks only about corticospinal tract, while there are a lot of more other tracts in the brain and cord, and the same mechanism can happen, and Wallerian degeneration could happen in other anatomical tracts, and we can see the imaging evidence of those. So I'm going to go through a few. Again, I'm going to start with corticospinal tract, which is the most well-known cause of Wallerian degeneration when it gets injured, which starts from the motor cortex and travels all the way through the cerebral peduncle and pons and medulla and anterior corticospinal tract. And if you have an infarct or a tumor or anything that injures the corticospinal tract, you can see the Wallerian degeneration downstream. So this is the initial presentation of a patient that had some infarcts in the corona radiata on the left side. And then after 5 months, the infarct is now chronic. It's a chronic lacunar infarct, but you can see abnormal signal intensity in the cerebral peduncle, indicating Wallerian degeneration of the corticospinal tract. This is an infant that has a right MCA infarct, and sometimes in pediatric population, especially in very young infants, you can have restricted diffusion associated with Wallerian degeneration that we can see here. And again, this is a pediatric patient with chronic left MCA territory infarct that we can see chronic Wallerian degeneration of the corticospinal tract with significant atrophy of left cerebral peduncle. So again, that's well known. I'm sure that probably all of you were aware of corticospinal tract, but when it comes to other forms of Wallerian degeneration, then sometimes a lot of folks are not aware of them. So this is a case of Wallerian degeneration of pontocerebellar tract, which is the tract that is between the cerebral cortex, pontine nuclei, and cerebellar hemispheres through the middle cerebellar peduncles. And so when you have an infarct in the pons, as you can see here, by abnormal flare signal intensity and restricted diffusion, this is a trace diffusion, and this is ADC. So this is the acute phase that we see the acute infarct, and everyone agrees. And after 5 months, patient comes back for a follow-up, and you can see the infarct again, now chronic. It suppresses on flare, but we see bilateral abnormal flare signal intensity in middle cerebellar peduncles, no restricted diffusion. So these are not new infarcts, but what they are would be Wallerian degeneration of the pontocerebellar tract. Again, very important not to misdiagnose them as some new infarct or demyelination or some metabolic disease, because they are symmetric, and the knowledge comes from neuroanatomy and knowing that these are the tracts that will be involved in Wallerian degeneration due to the infarct. Another tract that I want to emphasize for you is mammillothalamic tracts. So if you look carefully on these T2 weighted images, you can see 4 dots. Okay, and basically these 4 dots, the anterior dots are the fornices, and then the posterior 2 dots are the mammillothalamic tracts. And you can see the 4 dots also very clearly on flare. Again, fornices and mammillothalamic tracts. And the reason I'm showing you is that both of these tracts terminate in mammillary bodies. So fornices, we know that they come from hippocampi and then terminate in mammillary bodies. But again, the mammillothalamic tracts also terminate in mammillary bodies. So you can see the mammillothalamic tract here and the columnar fornix here. And so what it means is that if you have an infarct or any pathology in the anterior thalamic nuclei, then you can have Wallerian degeneration or downstream atrophy of mammillary bodies. It's an example of a patient who had an infarct in anterior thalamic nuclei, and then you can see atrophy of the ipsilateral mammillary bodies. And so I already showed this slide. So, and then I'm going to move on to dentorubro-olivary pathway, or the triangle of Guillain-Molleret. And this is in between the red nuclei, dentate nuclei, and olivary nuclei of the medulla. And any damage in any of these structures could basically cause hypertrophic olivary degeneration. So if you have infarct or tumor involving red nucleus or dentate nucleus of the contralateral side, because of these pathway, you will end up having hypertrophic olivary degeneration. So you can see a patient that had a tumor kind of involving left cerebellum, also extending into left superior cerebral peduncle. And after resection of the tumor, the patient developed hypertrophic olivary degeneration of the contralateral olive. You can see it's bright, it's a little bit expansile. So based on the anatomical location of the tumor, that can inform us that we're dealing with just a known pathway that happened because of anatomical tracts that have been damaged, and nothing needs to be done for this patient. And you can see on 6 years and 3 years and 6 month follow-up, the kind of olive went back to its normal shape. It's no longer specifically bright or hypertrophied. So that's kind of the normal evolution of the dentorubro-olivary pathway kind of injury and hypertrophic olivary degeneration kind of evolution of signal changes. One interesting thing that we might see in this entity is that if you have susceptibility weighted imaging, the red nucleus, which involved in hypertrophic olivary degeneration, could over time decrease its signal because of loss of kind of minerals, and the susceptibility weighted imaging can have this appearance on the red nucleus. And finally, we're going to move on to posterior column of the cord when it gets involved by Wallerian degeneration. Again, you know that we have basically posterior column of the cord, which are cuneate and gracile fasciculi that travel from the posterior column and eventually become a medial lemniscus, go to the thalamus and eventually into the sensory cortex. And what happens during a surgery like this is that a patient has a cord tumor enhancing T2 signal, some edema, and patients underwent resection of the tumor. As you can see here, this is the 2 weeks after surgery. You can see that the tumor has been resected. It's a pretty good resection. The edema is less compared to the pre-op study. But when you look at the follow-up, 3-month follow-up after surgery, you can see some new T2 signal that is new compared to post-op. So again, the question is that what is it? Is it some edema? Is it some tumor, or is it concerning or not? But when you look at the axial T2 of the spine, you can see very linear abnormal signal posteriorly involving the posterior columns of the cord, indicating that we are dealing with Wallerian degeneration of the posterior column of the cord due to injury to the posterior column during cord surgery for tumor resection. So again, this is not concerning at all. This is just Wallerian degeneration of the cord. And so moving on to vascular structures, I'm going to talk about developmental venous anomalies. And these are, again, extremely common. And again, this is a review that we published quite a few years ago from Penn, and Dr. Memorial is also on this publication, as many of my other publications. And basically, developmental venous anomalies are kind of some aberrations in venous drainage of the brain compared to normal venous drainage of the brain, that many veins kind of connected together and then to a central vein, and they have a caput medoso appearance, so to speak. And frequently also they are associated with cavernoma, which you can see here. There is a large DVA in the opercular region. There is also a cavernoma, and cavernoma is can be recognized by its typical appearance because it has various blood products of different ages. And on susceptibility or GRA images, it causes significant blooming. On CT, it's usually hyperdense. So DVAs and cavernomas are frequently seen together. And sometimes DVA can have associated abnormality. As you can see here, this is a DVA in right corner radiata. And you can see some signal abnormality on FLAIR and T2. Again, another one, DVA associated with some FLAIR signal abnormality. So a percentage of DVAs can have some signal abnormality, and it could be just incidental and not progressive. So it's not necessarily concerning. But if you see progressive signal abnormality associated with a DVA, that could be an indication that it might be an atypical DVA and a DVA with outflow venous stenosis that may require a little bit of workup. And this is a good way for this slide, which is a venous predominant AVM that could kind of mimic a DVA. So you can see on this CT, a patient with left frontal intraparenchymal hemorrhage associated with significant vasogenic edema. But on cerebral angiogram, on the arterial phase, we see a DVA-like structure, but at the same time, we see an early draining vein. So this is not a DVA, this just looks like a DVA, but this is a venous predominant AVM. And so this should be treated. Another patient with kind of the same diagnosis that came with intraventricular hemorrhage. And this is the CTA that we see kind of a DVA-like a structure, which is concerning to see during the arterial phase of the DVA, the CTA. And again, on cerebral angiogram, we can see that there is an early draining vein indicating that this is not just a typical DVA, this is a venous predominant AVM. And so some of the abnormalities that can be associated with DVAs are better visualized on physiologic imaging, because DVAs kind of somehow change the hemodynamic of the local brain parenchyma. And if you do perfusion imaging, you can see increased perfusion in the DVA territory. And also, if you pay attention to metabolic imaging, for example, on FDG PET, again, you might see some abnormalities in the areas that DVA is located. This is a patient with a cavernoma and a prominent DVA in right cerebellum, as you can see on these very nice MIP images that were reconstructed from MPRH sequence. You can see on physiologic imaging, perfusion in this case, increased perfusion in the DVA territory. Another patient that has a DVA again in right cerebellum, you can see increased cerebral blood volume. And also these are the DCE permeability MR that again, the metrics are elevated. And this is a DVA in left frontal lobe that you see the DVA very clearly on susceptibility weighted imaging, because this is a vein and it's going to act like a vein, and it's going to be dark on susceptibility weighted imaging. But on ASL imaging, we don't expect veins to be bright. So DVAs should be dark on arterial spleen labeling imaging. If they are bright, then that could be an indication that there is an arteriovenous shunting. So, and finally, I'm going to move on to FDG PET and how it could show in patients with DVA. This is a study that we did a few years ago at Penn. And when we looked at FDG PET in patients who had developmental venous anomalies, we saw that 38% of them had some qualitative or quantitative metabolic abnormalities on FDG PET. And interestingly, DVAs that drained the gray matter showed significantly more hypometabolic changes compared to DVAs involving the white matter. This is a patient with a cavernoma and a DVA in right temporal lobe. And you can see on FDG PET that there is hypometabolism in right anterior temporal region compared to the left side, corresponding to the territory of the DVA. And another patient, DVA in left cerebellum. Again, you can see kind of a hypometabolic region corresponding to the DVA territory. And this patient, though, doesn't have significant hypometabolism in the DVA territory. So not every patient with DVA has metabolic changes on FDG PET, but some do. And it's important to be aware of this finding. And this is an example of why this is important. This is an image of a patient who had epilepsy, and the patient underwent MR. It just showed a DVA. PET imaging showed some hypometabolism in the left temporal region that was kind of attributed to the underlying cause for epilepsy, and the patient underwent left anterior temporal lobectomy. However, the seizure frequency didn't really improve. So probably the metabolic abnormality was just secondary to DVA. It wasn't the real underlying cause for seizure in this patient. So again, it's important to be aware of how the DVA could affect FDG PET. So to provide that alternative diagnosis that maybe what we see is just some physiological changes because of presence of a DVA rather than epileptogenic lesion. And finally, the last benign vascular entity in the brain is capillary telangiectasia that I want to talk about. And these are small areas of abnormal dilated capillaries in otherwise normal brain parenchyma. When you look at FLAIR sequence, frequently you don't see anything, no abnormal signal changes. On T1 post, you see some enhancement, usually faint. And on GRE or susceptibility weighted imaging, you see blooming. And capillary telangiectasias, if you do perfusion imaging, they are frequently very bright on perfusion imaging. And so that's like the characteristic imaging finding of a capillary telangiectasia. And again, sometimes you have multiple benign vascular kind of malformations of the brain next to each other. This is a patient that has a capillary telangiectasia of left thalamus and also a DVA. So capillary telangiectasia, no abnormal signal intensity on FLAIR, and faint enhancement on post-contrast MR. You can also see a DVA here. This patient had a DVA involving the upper pons and also multiple capillary telangiectasia in the pons. Again, faint enhancement and some susceptibility on GRE, no abnormal signal intensity on FLAIR. And again, why is it important? Because capillary telangiectasias are common and frequently coexist with serious pathologies like brain metastasis. So this is a patient that came to us and with history of lung cancer. And you can see that there is a lesion in left cerebellum with surrounding vasogenic edema. There is another lesion that's faintly enhancing. So are we dealing with two mets or one, which is very important decision because when you have a brain metastasis this size, the treatment of choice is gamma knife. And so do we have to treat this lesion or not? The answer is no, because this is just a capillary telangiectasia, because we don't see any abnormal signal on FLAIR, and we see some susceptibility on GRE and classic location. And sometimes you have to look at your prior imaging, like this patient that has a brain metastasis in the frontal lobe, and also has a faint enhancing lesion in left medial thalamus that shows some susceptibility on GRE, no abnormal signal on FLAIR. So there is no question that there's a big metastasis here. However, how about this lesion? What should we do with this? So fortunately, we had a prior study from 1 year ago when the patient was just being imaged as a workup for brain metastasis. And at that time, the only lesion was this left medial thalamic lesion, which is not a metastasis. This is just a capillary telangiectasia in somewhat atypical location. So again, knowledge of this entity would help us not to treat this lesion as a brain metastasis, which is unnecessary treatment, unnecessary radiation for the patient. And so this is my last slide, and I want to emphasize that anatomical variations are very common in central nervous system, and we as radiologists should be familiar with these variations to make accurate diagnosis and prevent unnecessary procedures. And so please feel free to ask any questions, and it was really a pleasure to talk to you about anatomical variations in the brain. And I'm going to stop sharing and